but also focus in identifying and mitigating the underlying factors that precipitate and perpetuate impaired healing. All right. I have a question, y'all. Probably I will not see the answers, but what do you call an alligator that wears a vest? Yeah, it is investigator. So, in the clinical practice, we are all investigators in the wound care setting. When we see a patient with a chronic wound, our first step is to ask why it hasn't healed. We look at the cause and also the barriers that are in the way of healing, like the stage of their chronic illnesses, the access to care, food, housing, their health literacy, how much they know about the health, their if glycemic control, nutrition, which is I cannot emphasize how important for wound healing. I will touch on that later. We need to know what is the perfusion status, what is the edema level, and the pressure points. While searching and confronting all the issues, barriers to healing, we try converting the wound back to acute wound setting, acute wound medium, to reset the healing process that was come to a halt. We call this process wound bed preparation. There are ongoing studies that try to identify what is changing, how is changing, what level, and why. But we know that there is a lot of changes in the chronic wounds at the cellular and genomic level. We do have quite a bit of tools, techniques to change the wound bed, such as debridements, advanced dressings, biologicals. Thanks to the medical technologies, our armamentarium is expanding by the day. Wound bed preparation is a dynamic process. Wounds changes quickly after every intervention. For that, we typically see our patients weekly. Now we briefly cover what we do to treat chronic wounds. We should go back to ancient times where we started the journey. This is Imhotep, the priest of sun god Ra, the first physician in history. I'm sorry, that we know the name of. And this is the infamous. So yesterday I was practicing the speech, and then I was keep saying infamous, infamous, and my son says, "Mom, it needs to be pronounced infamous. Like, how come it infamous become infamous?" But so infamous Simit Papyrus. It is written nearly 5,000 years ago, and most things the Imhotep authored it. What is remarkable in this paper, um, it is basically a case review paper. 48 strange. 48 cases organized around the anatomical location with observation, a diagnosis, and a prognosis. These physicians were remarkably advanced. They connected heart to pulse, and they recognized the ominous signs or ominous consequences of pulselessness. They understood that brain is the command center for movement and recognized the crossing of nerves from brain to limbs. But most impressive of all to me was the physicians made decisions on which patient to treat and which patient did not merit curative treatment based on the prognosis. The translator, the first translator of the document, called these prognoses as verdict. There were three: a disease that could be treated and cured, a disease that could be treated but cure is uncertain, and the hardest and hopeless cases where the physician did not offer any curative treatment. In ancient Egypt, part of the physician's duty was to recognize medical futility and to act accordingly. Those doctors with attached godlike powers knew what being a healer meant is not only being the curing person, but recognizing when cure was not possible and guide the patient to decrease the suffering from other with other measures. Fast forward to today, knowledge is not sacred as it was at their time, and the physicians are not God anymore. Yet, we struggle to name the futility. Many caregivers, even they recognize the futility, they hesitate and avoid talking about the talking about that and having conversations with the patients and families to say openly that curative treatment will not work. There are, of course, we understand there are many reasons for that, such as illness, and that today in modern society is very oftenly considered as the failure of medicine or physicians. And Institute of Medicine has pointed out how perverse financial incentives can discourage the use of person or patient-centered care, especially the palliative care. And they recommend, and today, especially, I am noticing as an older physician that young physicians are especially focused only on the curable conditions. And when the cure is not available, they either avoid the patient altogether or the condition altogether, and or they try to do everything they can to achieve some success. Anyways, one of the recommendations for Institute of Medicine to introduce the palliative care early in the medical education, teaching new doctors that when cure is not a goal, the physician's role is to guide patients with honesty and compassion. In this, we return to the ancient lesson that the healing is not all about curing. So, the palliation means to alleviate suffering. And when that suffering comes from the physical wounds, then we are talking about the palliative wound care. There are many major scenarios that we make this shift in the approach and philosophy of our care. The largest group of patients that we change the goal from curing the wound to the palliative wound care is when wound is unlikely to heal. Such as malignant wounds, wounds in advanced diseases such as end stage heart failure, or when there is severe ischemia that revascularization is not possible, or chronic wounds that have not improved despite the optimal care. The second largest group is the healing is possible but not feasible. Treatments will be too painful, too invasive, too much for the patient. Patients may have limited reserves, such as malnourished, severely malnourished, or very frail to handle the procedures, interventions that may be sometimes aggressive for the healing wounds. Burden of the procedures outweighs the patient's capacity to handle it. And the third group is the when wound care goals conflict with the patient's goals. Patient may be in the last stage of their life and in hospice eligible care patients. The patient and family may prioritize the quality of life. I had a patient wanted to travel to see her grandchildren, or aggressive wound care would interfere the life quality too much. And the last group, and not the least, is the when the wound symptoms are worse than the wound itself, such as pain, odor, exudate, bleeding, are too important to the patient or too severe. The wound affects mobility, sleep, or so on. And emotional and psychological stress of the wound is too much that we cannot focus on the wound. There is quite a bit of confusing terminology when it comes to the palliative wound care. When I review the papers regard in this field, I come across with various saying of palliative wound cares, such as palliation of the wound, palliative or wound of wounds of palliative patients. These are, if you analyze them in a terminology level, like a linguistic level, they mean different things. But I'm not going to confuse you more with all this because at the end, most of the authors are actually aiming the same thing: palliation of the wounds. But there are more confusion beyond that, um, um, which is we should talk about. Wound care language has traditionally centered on healing the wounds, healing trajectories. And when we shift the goalpost towards symptom control, dignity, and quality of life, there are some confusion arrives to the patients and the clinicians also. Most of the times they misunderstand that palliative wound care is a separate specialty, a separate discipline. Well, in fact, it's actually an extension of the wound care still, and with the palliative measures are added to the care. The In some settings, the palliative is equated with end of life or giving up. So families and even clinicians sometimes may resist to the label. It feels like withdrawing care or providing substandard standard care, when in fact palliative wound care still includes active, skillful, and compassionate treatment of wounds, but not as aggressively as we would otherwise in the non-palliative setting. There is, by the way, a hospice wound care, which is a subset of palliative wound care reserved for those who are in the hospice eligible status, living their last stage of life. At that setting, we totally do not do wound care or or just focus in the comfort measures only. This inconsistent terminology across societies, specialties, and even within institutions makes it difficult to build evidence, compare outcomes, or even create billing codes. For example, in the USA, the coding is tied to healing metrics, not palliative goals, which can undervalue the work with after equality palliative wound care application or practice. So, with that in mind, there's quite a bit of effort to describe the frame of palliative wound care. I am just going to go ahead and read these few historical from historically outlined definitions here to get a better understanding of the this wide frame. Ferris, one of the pioneers in the field, says palliative wound care is the evolving body of knowledge and skills that takes a holistic approach to relieving suffering and improving quality of life for patients and families living with chronic wounds, whether the wound is healable or not. Palliative wound care is an extension of both palliative care and wound care. Emerson Lackman is the description is holistic integrated approach to care that addresses symptom management and psychosocial well-being, is multidisciplinary, is driven by patient family goals, and is integrated into wound healing principles and everyday practice. And the last one probably is most comprehensive, is coming from the European Association for Palliative Care Wound Task Force, is says person and family centered, holistic and interdisciplinary care of wounds that may heal or not, or may be too onerous to treat, including but not limited to symptom control and management for individuals who are often vulnerable and have impaired quality of life. So I hope I was able to explain the frame, which basically what we do is in our clinic when we decide to make this shift for the reasons that I listed, we are changing, changing the aggressive management plans. We still continue wound care, but more focusing on the symptom management. Especially the symptoms that interfering and decreasing patient person's quality of life one way or the other. So, etiology of wounds requiring palliative wound care, according to the European Wound Management Association, is listed here in this pie chart. Most common etiology is the pressure ulcers, and then fungating malignant lesions, then diabetic foot ulcer, ischemic ulcers, and venous leg ulcers, and among the others is radiation injuries. According to the same survey that was, oh my gosh. That was an international survey based on 513 centers participants in Europe. The most common three symptoms with the palliative wound care patients was pain, malodor, and excessive exudate. Bleeding and itching followed. So we are going to talk about that now. Regardless of the etiology, probably pain is the most severe and most common symptoms, and especially common with the malignant ulcers and pressure ulcers. 50% of the malignant ulcers and more than 60% of the pressure ulcers patients complain of pain. Uh, with every patient in the wound care, we do a true pain assessment. Pain assessment especially can be complex in the patient with cognitive impairment and geriatric group. So using proper pain assessment tool is very essential, essential, and we assess pain frequently, almost every visit. And we try to identify the cause and triggers of the pain. It is very interesting and some many times surprising to me that very simple measures could be a trigger of the pain or cause of the pain, such as position. And most of the patients, or some of the patients at least, are not even aware that the cause. Many of the patients thinks the pain is an inherent part of the wound. Every time you have a wound, you will have a pain and you live with it. And sometimes if you don't dig in, you don't ask the question, they will not even admit to the pain issue. Dressing changes may be a one of the most important cause of the pain. For that, for these patients, we choose our dressings from the gentle types with less adhesives and less frequent requirement of changes, replacement. Always need to keep in mind that infection can cause a pain, undertreated infection, and also the cause of the change in the pain pattern. It is especially with the chronic wounds, signs of infection could be sometimes subtle. So that needs to be evaluated. So before pharmacologic treatments, we do have other tools to help with the pain. One of them is again understanding the triggers. If the patient is sitting in a place that is causing the wound as well as the pain, we do need to either understand that and make these changes. Or mobility sometimes can be a cause, and that needs to be controlled with devices. There is outstandingly well done virtual reality applications on the phone, headsets, or tablets that distracts the patient from the pain, and that can be used. Some mindfulness exercises, breathing exercises, and meditation, especially during the procedures or dressing changes, could be really useful tool. You probably do know this better than us when it comes to pharmacology of the pain, pharmacology for the pain. In clinic, we most of the time we try to use the topical remedies instead of systemic. Of course, sometimes we do use systemic treatments, but usually we use a very short term when we choose to use the systemic treatments. This is the table that outlines the some off-label use of topical remedies. Among them, most commonly, our workhorse is the local anesthetics, topical local anesthetics in the clinic. Almost all patients receive that before exam and treatment. Sometimes we prescribe that to patients for home use, especially for procedural pain like dressing changes. and they work for the rest pain too, but we have better treatments for the rest pain. In Europe, they use topical sevoflurane a lot, and because it provides apparently 8 to 10 hours of pain control. And methoxyflurane is not available at the moment for us. It is another medication that used in Europe in emergency settings too. And if last I heard that FDA lift the hold status for this medication and probably will be available to us within 1 2 years. Topical ketamine also seem to be working well. We don't use much, but some pain clinics use topical ketamine as well as the topical opioids. So Molodor could be a very disturbing symptom of the wounds. It is associated with the increased bioburden, especially the anaerobic bacteria, the chemicals that release from their metabolism, their side products. The normal exudate is odorless, but every wound has a profile, a bacterial profile. Everyone get colonized with bacteria, and everyone, due to their byproducts, have some smell. Many dressings cause smell. For example, alginate causes fish-like smell when it gets made with exudate. But the molodor could be quite disturbing to patient and also the people caring for them, and can lead to odor, the isolation, and that needs to be addressed. And addressing molodor should be simple. Just cleaning the wound, debriding the necrotic tissue, and using some antimicrobial dressings containing silver or iodine or the other halogens. And honey could be very helpful to control the odor. Topical metronidazole is one of the most commonly used, especially outside. We always get questions for it from the patients and the providers. Gel form is available, 75%. It's quite expensive, although some of my colleagues lift their eyebrows because it can cause some irritation. We typically use a tablet, crush it, and then sprinkle over the wound daily. Um, it is much cheaper, much cheaper, and it does good job. We 2 weeks of treatment usually is more than enough to control the Molodor. Secondary dressings, I think, works very well for this. There's dressings made with the activated charcoal and cinnamon, but they are expensive. Grandmother's application using the sprinkle the powder of inactivated charcoal or cinnamon over the other dressing, not over the wound, but other dressing, is very successfully absorb the chemicals that causing the malodor. It works pretty good. Systemic antibiotics has no roles using the controlling the malodor unless there is infection at the one side. We advise patients, if we cannot, or it is a chronic issue that patient cannot come to office frequently for cleaning wound, etc. We advise them to use some odor absorbing odorless sprays that are available, many of them. They do a great job. Shaving foam or cat litter in a cup next to the patient would be a very good application. They absorb the smells. And changing fabrics frequently would be, of course, would be the best. Also, the one thing they should not do is to adding another odor, such as incense or deodorant. That makes things worse. So one exudate is sometimes excessive. The drainage could be excessive. Normal wound exudate is important for wound healing. That is the one that media causing all the communications between cells, carrying the hormones and cytokines, etc. It's essential for wound healing. But when it gets excessive, then it is disturbing, and also it is disturbing for the skin around the wound as well. It When it sits on the skin for prolonged periods. So that's we need to identify and address. Most of the time, there is correctable reason for excessive drainage, such as increased swelling, such as infection, or ongoing pressure or trauma, all cause excessive drainage. And if we can identify and address with the proper compression, avoiding using some offloading devices or treating the underlying infection, then it's gonna go back to normal level, average level of exudate. No, if the exudate sits on the skin, it does break the connections between the epidermal cells and can the maceration will break down the edges and make the wounds worse. For that, we do have some tools like unilaterally, unidirectionally transferring membranes, which are quite expensive. This is the diaper technology, basically. And there is some very super strong absorbers, like super absorbers dressings. They are not easy to bend and they are not good with conformation, especially certain areas over like heels, over the sacral area, etc. We get creative on that. Some very commonly we use diaper, for example, diaper or depends, that work very well. Increasing frequency of the dressing changes at the period where excessive the drainage is large is helpful. Some, if there is a fistula, such as lymphocutaneous fistula at the leg, or abdominal wounds with the intestinal or enteric fistulas, we sometimes treat that with the fistula care, creating an ostomy, adding an ostomy bag. And if we cannot do anything, using negative pressure wound therapy, uh, just for that purpose, this removing the exudate is a very practical and productive way of using the technology. Bleeding could be quite distressing for patients. It is especially important for the malignant wounds. Very stressing for patients. They always feel like they are going to bleed to death. And in fact, it can happen. Based on the case review with 90 patients, they found that 40% of the patients have frequent bleeding, and about 20% had significant bleeding, and 2% died of bleeding. And most common trigger or the reason for bleeding was the dressing changes, 80% of the time. The normal wounds, other wounds, for the non-malignant wounds, bleeding always implies some sort of a trauma, and so we try to identify that to guide patients to on that. So for the high-risk wounds with the bleeding, patient and caregiver education is important. We show them how to apply the pressure, how long to apply the pressure. Cotton is most commonly used with its negative charge, cause platelet activation and aggregation. The problem is it cause fibrin plaque to be um, come with the dressing and cause rebreathe. But oxidized cellulose and oxidized regenerated cellulose, which are products of cotton, are very good. You don't need to remove them. You keep them on the wound, and they do a good job for controlling bleeding. Bioactive dressings, thrombin and fibrinogen are super expensive, so we don't use them. But collagen, it's the naturated form, gelatin, which has a foam available. Alginate, they do great job activating coagulation system and stopping bleeding. Alginate has the same problem with the cotton, removes the fibrin clot when you remove the alginate if it is dry. There's a new product called chitosan. It is made from chitin, the shellfish exoskeleton. It is a very potent hemostatic agent. For high-risk patients, we prescribe this dressings to them. There is also I forgot to say, Afrin, how it stops the nosebleed, also can stop the wound bleeding. And then there are some active hemostatic chemicals. We prescribe this and teach them how to use them, because especially smectite and MOS can cause some normal tissue destruction. Smectite is just clay, actually, volcanic clay, and MOS is zinc chloride. Kaolin coated polyester roll gauze, which is quick clot, is available over the counter. Also, it's highly effective, most used in the military. These are active compounds that are going to stop bleeding very effectively at home, and they should keep it at the shelf. Yeah, Puritus is a very nasty and some it's very difficult to get rid of for patients. For wound care standpoint, I know it's a big problem with the geriatrics and especially with the other systemic illnesses too, especially dermatologic. But wound care, it is almost always associated with inflammation, and it is most commonly seen with the venous stasis ulcers because venous stasis at the end is a inflammatory condition, and even without ulcer, patients with the venous insufficiency, pruritus is a cardinal sign. For that, we do need to treat underlying cause, whatever causing the inflammation. Despite that, though, it could be destructive. Patients sometimes just tear open their wounds and their skin, scratching even knowingly. So for that, there are some measures we need to take, such as avoiding dryness of the skin, avoiding heat exposure, skin irritants, avoiding maceration, because after maceration, if this tissue desiccates, like dries out, it is even more itchy. We do use levomantol sometimes, although it can cause irritation if we keep it on the skin too long. Um, it cools off the skin. It helps. By the way, about the cooling the skin, I need to mention that icing is commonly used in practice for itch, which can be very harmful to skin and the what you call the wound. The I just recently had a patient, a physician, who has venous insufficiency and has bought this compression pump. It is circulating the ice cold water, and what he's doing is keeping that pump on all night long. The pump instruction says just 10 to 15 minutes use. So when you use that ice cold water on the skin, then it is going to break down the skin because, and wherever it is weaker, especially the vulnerable skins like venous stasis legs or this post-surgical incisional wounds or scars, and then it will not allow the healing because for wound healing we need vasodilation, and ice prevents that. It causes constriction, constant constriction. So for it, please keep in mind for itching, icing is only allowable for 10-15 minutes, not longer than that, and between that, skin should reach the normal temperature. Um, capsaicin can help with the itch, and also some compound with ketamine and amitriptyline is available, or you can make it at the office. For intractable itch, we sometimes have to use some anti-seizure medications as well. So I cannot emphasize the importance of nutrition for wound care. So when there is a nutritional deficiency of anything, especially protein and essential mineral and vitamins, body does not prioritize skin and skin healing. Um, and until this gap is completely filled and reached to a positive balance. That's we need to keep in mind. With that, malnutrition is one of the most important barriers for wound healing. Sarcopenia is our current most common encountered problems with malnutrition, with or without cachexia or obesity, is an independent risk factor for delayed wound healing because it is really hard to reach the positive protein balance with sarcopenia because of the decreased muscle mass. So this needs to be delayed as much as possible by encouraging patients for physical activity. The importance of malnutrition is so deep that in hospitalized patients, it is major risk factor for developing pressure ulcers. For palliative wound care, management of you know better than me how difficult management of malnutrition in geriatric population as due to their decreased senses and access to food options. Anorexia and cachexia are common in patients with life limiting illnesses, hence their wound and wound among this population. Weight loss is associated with poor outcome of all diseases, and wound care is probably at the top of that list. Addressing nutritional support, whether the patient is in active wound care or palliative wound care, is essential to us. We screen every patient for malnutrition and talk to patient and family regarding the importance of malnutrition. Despite that, though, recently I had a patient, a Duchenne muscular dystrophy with the pressure ulcer. We are not getting anywhere. Family and patient is super involved, doing everything we say. The one is just like on the sitting there, not doing anything. And then and this patient has the gastrostomy tube for feeding. So and for years, and I'm always thinking that when there's tube feeding, there's always some dietitian consult and proper supplements, right? And the patient goes into hospital for some pulmonary issues, and there he's diagnosed with scurvy. So that was the reason that wound was not healing. So we need to clarify the goals with patient and family. Sometimes patients are resistant to eat or they just don't care. And it is okay to advise these patients whatever they can eat, ice cream, shakes, whatever they can enjoy eating, they should eat because we need all the calories and proteins we can get. Let's talk about some cases here. First patient is a 94, and during this time, please participate. And I appreciate any comments or questions. This is first case is a 94-year-old woman with cerebral amyloid angiopathy and with cerebral hemorrhage history, mild dementia, combined heart failure. She is bedbound and wheelchair bound due to the multiple pathologic vertebral fractures and recent sacral fracture. She is seriously underweight. Um, Comes with this wound. The family says that she always had this butterfly skin erosion there for 6 months, 7 months, maybe longer. But within the last 2 weeks, it became serious with this increased drainage, increased pain, and wound looks necrotic, as you can see. A patient was given alternating air mattress powered. He couldn't tolerate with her frail body. She has a manual wheelchair cushion, wheelchair and wheelchair cushion. Um, the main complaint is rapid progression, position pain, which pointed out that it was positional. Patient's family recently got her a new recliner chair with the hard cushion. Patient was spending entire day and night in that cushion. When you recline, you put pressure to the sacral area. So, and patient was in pain in this chair, but she wasn't complaining until we asked her. And this caused that wound to worsen as well, along with the large exudate again, because one of the reasons for large exudate is the pressure and malodor. So what we did, we debrided this wound. We consult the patient for nutritional support, hygiene, and proper skin protection. As you can see, skin is nicer now. And we use antimicrobial absorbent dressing. We arranged a home health nurse to take care of the dressing changes. And we also prescribe her proper wound wheelchair cushion for the medical appointment and such. She spends time. She spent, yeah, okay. The wound improved quite well, as you can see, uh, and almost healed. Then she comes with two new ischio wounds. You see, the sacral wound was here up there where the label is. It almost healed. It's you can see it's small. These are new necrotic wounds because the new caregiver uh, kept her on chair, took her to some kind of activity, and she, after sitting in the chair upright position for a long period of time, she developed new pain, new ones, and now we are taking care of that wounds. This is a case I think we cannot win. This is a 57-year-old woman. When she first come to us with a leg ulcer on the right side in 2022, she reported that as an insect bite. Take my word on this. Insects are 99.9% of the time are innocent when it comes to the wounds. This patient has polysubstance use disorder, um, and she is not very willing to come to wound care visits. Since then, wounds never healed, gradually worsened and worsened and worsened. They are super painful. She doesn't let us touch but when she makes it to appointment, which is every one out of four, 3 or 4 visits. She doesn't let us use any compression. We put compression, she removes it the next day. Um, we um, we cannot really do too much. We had multiple visits with her to go over the goals and set some management options, monitored infection and treatment. We communicated with her primary care doctor, who is a young, very dedicated, very compassionate internist. Well, I'm sure she's thinking we are not doing a good wound care for her, by the way. But we cannot really stop the progression. The she personally I personally think that this is because she's gaining secondary benefit from the wounds. It is the cause of using fentanyl while on methadone program. It's the cause of failing the inpatient rehabilitation, using alcohol regularly, and getting lots of empathy from the healthcare providers. So this is sometimes we cannot really win, even we do try to utilize the palliation measures with every case. This is a 49-year-old woman with cerebral palsy, with spastic quadriplegia, severe intellectual disability. She lives in an apartment with 24/7 caregivers. We admitted this patient with unstageable pressure ulcer at the left buttock and at stage 4 ulcer on the ear. So we debrided the wound, as you can see here. We what we did, we educated the trainer, the caregivers for the proper positioning of the patient to avoid sitting in the chair, perineal hygiene, nutritional improvements. We diagnosed the osteomyelitis and treated it. And we continue seeing the patient once a month to monitor along with the home health nurse, because they can reach us quickly if there's a problem. And so we can see the patient faster. We improved to monitor patient for infections and treat if we need to. We carry out some gentle debridements intermittently. A patient's seats and bed was improved to group 2 to improve the offloading, and she's doing fairly good. The wound is more superficial, not exposing bone anymore. Probably it's not going to heal. It's not our goal, but as long as we can keep this wound from worsening and getting complex, we will be good. So this is a patient I'm presenting because I feel we were too late to initiate or switch the goal to the palliative wound care. This is 74-year-old gentleman, transgender on testosterone, high dose, very long time. He has progressive limb-threatening ischemia with diabetes as well. He initially came to us with right foot ulcers. And despite all the efforts and revascularization attempts that were unfortunately were not long living, they closed up quickly. Um, Eventually, he had right BKA. It was complicated with abscess and osteomyelitis, required revision. And then he had another revascularization attempt on the left side that caused the compartment syndrome and had fasciatomies. He has a long-standing chronic right great toe ulcer. So eventually he said he got enough. He is not going to have any further painful procedures. Already he has severe ischemic pain. And so we finally decided to move to palliative wound care on him, where he knows how to diagnose the infection when there is changes in the wound features. We are using antimicrobial moist dressings. We still will use intermittent short course of antibiotics. He was referred to pain clinic. He's on opioid and gabapentin, and we following up to treat. So this is our last slide. I think good timing. When we talk about palliative wound care, we are really talking about a shift in perspective. It is moving the goal from simply trying to close the wound to focusing on the person who carries it. That means our care must go beyond the physical wound. We have to acknowledge the emotional and practical challenges faced by the patient. Equally important is setting realistic goals. When expectations are shared and understood, collaboration with patients and families becomes stronger and care feels more meaningful. By addressing symptoms that causes distress, things like pain, odor, large drainage, we can help preserve dignity while reducing the isolation. We know that empowerment matters. When patients and caregivers understand and educated and equipped with the knowledge and skills to manage the wound complications to a level, they feel much more secure. Fear reduced, complications are minimized. And finally, let's not forget the caregiver themselves. They are be recognizing and validating their effort, their burden is vital. It not only improves communication, but it strengthens the circle of care around the patients. Thank you very much for sparing your time for me this morning. This is all I have. And if you have any questions, I am available.